Great. So welcome everybody to Online with the Experts, which we are rebranding as ONTPD Grand Rounds for academic year 2024-2025. We are really thrilled to welcome Dr. Jeffrey Kaiser as the speaker today. He is the chief of the Division of Neonatal Perinatal Medicine and the inaugural holder of the Kenneth V. and Eleanor M. Hatt Professorship of Neonatal Medicine at Penn State Children's Hospital. Dr. Kaiser has been an active researcher funded by the NIH for his own work about intraventricular hemorrhage, cerebral autoregulation, and as site investigator for trials in the NICHD network all around neonatal neurology. His current research focuses on hypoglycemia. He is a mentor and an administrative leader in his current roles, and we're very fortunate to have him presenting about neonatal hypoglycemia today.
Deirdre, thank you for inviting me. I look forward to sharing some newer information about transient neonatal hypoglycemia that actually has a shared mechanism with genetic hyperinsulinism or congenital hyperinsulinism. So I have nothing to disclose other than I live and work in the sweetest place on earth. So our objectives today, oh, actually, also, I'm fine with people interrupting me to ask questions. Don't wait till the end. So it doesn't. I'm fine with that. So we're going to talk about controversies about transitional neonatal hypoglycemia. We're going to discuss the three major forms of newborn and neonatal hypoglycemia: transitional or transient hyperinsulinism, perinatal stress-induced hypoglycemia or prolonged hyperinsulinism, and then lastly, congenital or genetic hyperinsulinism, which is persistent hyperinsulinism. We're going to review the mechanism of insulin secretion from pancreatic beta cells in newborns and discuss the shared mechanisms of all three forms of newborn and neonatal hypoglycemia. They are all due to hyperinsulinism. There is a much lower glucose threshold for insulin secretion in newborns, and they all work through the pancreatic beta cell potassium channels. So I'm going to tell you at the beginning what my key points are, and then we'll go through each one. So the first thing, transitional neonatal hypoglycemia has no long-term adverse effects, and no one has ever shown that treatment is beneficial. Number two, transitional neonatal hypoglycemia, again, I'm talking the first 24 to 48 hours, is due to hyperinsulinism. And early neonatal hyperinsulinism is caused by low glucose threshold for insulin release. And this early neonatal glucose threshold that's very low is caused by decreased trafficking of potassium channels from the cytosol of the cell to the surface membrane of the beta cell. I will also talk about traditional newborn hypoglycemia screening programs, the AAP, the Pediatric Endocrine Society, other international groups. They do not meet criteria for being good screening tests. And lastly, I'm going to propose that we do routine newborn bedside monitoring of glucose and ketone concentrations right before discharge of otherwise healthy babies in order to screen for prolonged and persistent hyperinsulinism. So first, I'm going to show you the GLOW study, or the Glucose and Well Baby study. And this is a relatively recent study by Deb Harris et al. From New Zealand that documented the new normal pattern of glucose concentrations during the first 5 days after birth in otherwise healthy term newborns that were mostly breastfed. So here is the 10th to 90th percentile. And on the x-axis is hours after birth. So levels slowly increase over the first 18 hours after birth. Then they kind of stabilize around 48 hours. They then increase over the next 2 days up to 96 hours. And finally, they reach adult levels or greater than 70 by day 4, day 5. So to discuss newborn glucose concentration naters, normal maternal glucose levels are 70 to 100. And at term, a fetus is about 10 milligrams per deciliter less than the mother. After birth, levels drop by at least 10 to 15 milligrams per deciliter, sometimes more. And this is a study that we did back in 2018. In the black are full-term babies. In the blue are late preterm. In the green are preterm. And then lastly, LGANs are in the red. And so in normal term newborns, the nadir reaches about 55 to 60, and that's at about 1.5 hours after birth. And preterm babies have earlier glucose nadirs. So you can see preterm, 28 to 32 weeks or so, they nadir at around 70 minutes. LGANs nadir at around 60 minutes. But one of the interesting things is late preterm babies also have nadirs around 90 minutes. But all along that first 3 hours after birth, their levels are about 5 milligrams per deciliter less than term infants. And this was done in over 1,400 babies. So there are significant controversies about what hypoglycemia is and what is significant hypoglycemia. So the definition of clinically significant newborn hypoglycemia, according to Marvin Kornblath in 2000, and he is one of the fathers of this field, is one of the most confused and controversial issues in contemporary neonatology. And I have to say, 24 years later, we still do not know exactly what to do, especially with transient neonatal hypoglycemia. And it's really difficult to discern a precise glucose concentration at which time neonatal hypoglycemia shifts from being physiologic to pathologic without really knowing the mechanisms of neonatal hypoglycemia. Further, there are tons of knowledge gaps that persist. Is it a normal physiologic phenomena, or is transient neonatal hypoglycemia associated with cognitive impairment and brain injury? Which newborn should be screened? What is the glucose concentration that defines it? Is there a glucose concentration that defines it? What is the glucose concentration threshold that we should use for treatment? And what treatment should be used? Does treatment even improve outcomes? And importantly, what's the mechanism of transitional neonatal hypoglycemia? So, practical recommendations from international societies are based upon what I call eminence-based decision-making rather than evidence-based studies. And importantly, neonatal hypoglycemia may be one of the most preventable causes of brain injury, or on the other hand, overtreatment of this probable non-disease actually may lead to decreased breastfeeding and permanent brain changes from repeated painful heel sticks. And this is an important point. Most studies conclude there are no long-term adverse effects to transitional neonatal hypoglycemia. And further, treatment has never been demonstrated to be of benefit. So you may ask, why do we keep checking these otherwise healthy babies? Why do we pull them away from their moms? Why do we give them treatments when no one has ever shown that it's beneficial? And perhaps it's harmful. So, key point number one, transitional neonatal hypoglycemia has no long-term adverse effects, and its treatment has not been shown to be beneficial. So I'm going to show some of the studies from New Zealand, from the child study group. And this is where most of the recent neonatal hypoglycemia studies have come from. So they did prospective cohort studies of normal glycemic versus hypoglycemic at-risk newborns. And importantly, they screened these babies and treated them to maintain glucose levels above 47, or 2.6 millimoles per liter. And they assessed these babies at age 2, 4.5 years, and 9 to 10 years. So let's look. At age 2, the light blue is normal glycemic and the purple is the hypoglycemic babies. No difference in neurosensory impairment, no difference in processing difficulty. Let's look at 4.5 years. No difference in neurosensory impairment, but they actually found that there was more executive function disability and visual motor problems in the hypoglycemic babies compared to the normal glycemic babies. And these were statistically significant. Now, importantly, at age 9 to 10, they looked for low educational achievement. And so there was no significant differences between normal and hypoglycemic babies. So the conclusion of these studies are for at-risk newborns greater or equal to 32 weeks who were screened and treated to keep levels above 47. At 2 years, there was no difference. At 4.5 years, perhaps executive function and visual motor integration problems. But then at age 9 to 10, there was no difference in how they performed in 3rd and 4th grade. It's really unclear why there were differences at age 4.5, but not at age 2 and age 9 to 10. Perhaps this is just statistical confounding, but in general, these studies do not support that transient neonatal hypoglycemia has any long-term adverse cognitive effects. So the same group, again, led by Deb Harris in this elegant randomized controlled trial called the Sugar Babies study, they looked in at-risk. Now, these were hypoglycemic babies, and their question was, does 40% dextrose gel, is it more effective than just feeding alone for reversing neonatal hypoglycemia? This was a randomized controlled trial. Half got 40% dextrose gel, half got placebo gel. And these were all babies that had values less than 47. The primary outcome was treatment failure, i.e. glucose below their threshold after 2 gel applications. They looked at neurocognitive outcomes, again, at age 2, 4.5, and 9. So age 2, for the babies that were hypoglycemic, but in red were treated and in green received placebo, no difference in neurosensory impairment, no difference in processing difficulty. Let's look at 4.5 years. Interestingly, no difference in neurosensory impairment between dextrose gel and placebo. But interestingly, in the babies that got dextrose gel, they did worse significantly in visual processing than did those hypoglycemic babies that just were fed. And then at 9 years, academic achievement, in fact, was no different by p-value, but, quote, the trend showed lower educational achievement in the dextrose gel babies. But importantly, in vision, again, the babies who received dextrose gel did worse than the placebo babies. So the conclusion of the sugar babies trials, again, these are at-risk babies who are all hypoglycemic. No difference at age 2, 4.5, and 9 in neurosensory impairment and educational achievement, and perhaps worse visual processing at age 4.5 and 9, i.e., placebo gel in these hypoglycemic babies perhaps was worse than not getting treatment at all. I.e., these studies do not support that treating transient neonatal hypoglycemia improves long-term neurocognition. So let's look at the American Academy of Pediatrics guidelines for the treatment of and the screening for glucose homeostasis in late preterm and term infants. So if you look in the from birth to 4 hours, you would feed within the first hour. You would screen glucose 30 minutes after that first feed. But if the initial screen was less than 25, you could either put in an IV and send the baby to the NICU, or you could decide, or if there was kind of a middle of the road glucose concentration, you could either refeed or just put in an IV. Next, if you looked at 4 to 24 hours after birth, their important value was less than 35. And they suggested that if it was less than 35, go to the NICU for an IV. And if it's between 35 and 45, either put in an IV or refeed the baby. But ultimately, they were most interested in targeting glucose concentrations above 45 prior to routine feeds, literally from birth. Now, we're waiting for the new AAP guidelines. I can tell you, and I've seen them, but I can't tell you what they found. It's going to be much more complicated in what we do. And still, there's no evidence that it is a disease or that its treatment improves outcomes. Next, 4 years later, in 2015, the Pediatric Endocrine Society made recommendations. And they specifically talked about transitional neonatal hypoglycemia. And they simply said, in the first 48 hours, simply stabilize glucose concentrations. Now, for high-risk newborns, without what they thought was a hypoglycemic genetic disorder, they really thought that the goal of treatment was to maintain preprandial plasma glucose concentrations greater than 50, even at time 0. So this is much more conservative than the original AAP guidelines. And then after 48 hours, if you're persistently hypoglycemic, then you need to do a workup. Okay, key point number 2. Transitional neonatal hypoglycemia is due to hyperinsulinism. So we know that transitional neonatal hypoglycemia affects about 15% of healthy term newborns and up to 50% of at-risk newborns. It's also called transitional hyperinsulinism. That really describes more of its mechanism. It's transient and occurs within the first 48 hours after birth. It is a hypoketotic hypoglycemia. there's a lowered glucose threshold for glucose-stimulated insulin secretion, i.e., newborns secrete insulin at lower glucose levels. There's an inappropriate preservation of glucose stores in the liver. So when you give glucagon, glucose levels go up more than 30. And it really resembles congenital or genetic hyperinsulinism. So going back to the GLOW study, in addition to measuring glucose in the blue, and these are mean values, they also measured beta-hydroxybutyrate in green and lactate. And I'm not going to show you the lactate at this moment. But based upon the GLOW study, there are two phases of neonatal hypoglycemia. So the first one occurs in the first 24 hours. It's a relative hypoketotic, low ketones, hypoglycemia due to hyperinsulinism. The second phase, perhaps, is around 48 to 72 hours or so. In this situation, you can see that ketone levels are now relatively elevated, and this is thought due to mildly ketotic fasting state when breast milk is not fully in. And there are these distinctions. The hypoglycemic, the hypoketotic and the normoketotic or hyperketotic of sorts. And again, that was due to fasting, relative fasting. So now we're going to talk about briefly perinatal stress-induced hypoglycemia. And this syndrome of prolonged neonatal hyperinsulinism has really gone under the radar, and it's much more common than genetic congenital hyperinsulinism. Probably it's about 1 in 1,200 newborns. It lasts for variable lengths of time. It's more than 48 hours. These babies have hypoglycemia due to hyperinsulinism. Their ketones are very low. They sometimes require GIRs of up to 20 to 30. They often need and most respond to diazoxide. Some of these perinatal stress-induced syndromes of sorts last up to 400 days, but they do spontaneously resolve. And they're likely due to fetal hypoxia and possibly elevated catecholamine levels. These are babies who have placental insufficiency or birth asphyxia, SGA or HIE, congenital heart, intrauterine infections, meconium aspiration babies, premature babies, preeclamptic babies. Next form is congenital or genetic hyperinsulinism. And these are predominantly due to potassium channel inactivating mutations. So the two most common, and this is a board question, is the KCNJ11 and the ABCC8. These are the most common potassium channel genes affected, and they lead to congenital hyperinsulinism by increasing beta cell membrane electrical excitivity or repolarization. It's characterized by persistent, unregulated, inappropriate insulin secretion, and it can result in life-threatening or hypoglycemia that causes very bad brain injury. The genetic variants of these potassium channel genes, they prevent or reduce channel trafficking, the potassium channel, from the cytosol to the plasma membrane, or they just make the potassium channels not functional. Most of these babies are unresponsive to diazoxide. There are a bunch of other medications. There are some experimental medications, and some require focal or almost total pancreatectomy. So moving on, we're going to talk about the mechanism of insulin secretion in newborns. in response to glucose concentrations. So let's focus on the pancreatic beta cell. Okay, so here's a beta cell. And in the membrane is a GLUT2 glucose transporter, and it passively allows glucose into the pancreatic beta cell. Next, glucose is metabolized through glycolysis, the Krebs cycle, oxidative phosphorylation, and it produces ATP. So when the ATP to ADP ratio is high, resulting from metabolism of glucose, it actually inhibits these potassium channels here. It does not allow potassium to escape the cell, i.e. the inside of the cell becomes less negative. Then there's a depolarization of the membrane, which leads to increased calcium that comes in through voltage-dependent calcium channels. This increased intracellular calcium then triggers the secretion of insulin granules outside of the cell, leading to insulin secretion. And that's the mechanism. So importantly, intracellular ATP is proportional to intracellular glucose. And interestingly, it's also proportional to the glucose in the blood, i.e. it passively goes through the GLUT2 transporter. So the biologic sensors of blood glucose linking glucose to insulin secretion are the potassium channels, and they do this by modifying the pancreatic beta cell membrane excitability. So this shows the effect of low blood glucose concentrations on beta cell potassium channels. So you're fasted. Your intracellular ATP is low, i.e. your ATP is high. Potassium channels remain open. Potassium goes out. The membrane is hyperpolarized, and that leads to a cessation or no insulin secretion. In contrast, after you eat a meal, glucose comes into the cell. It increases the metabolism of glucose. There's increased ATP. This leads to potassium channels being closed and membrane being depolarized, leading to insulin secretion. So, modulating the number of cell surface potassium channels by trafficking channels from the cytosol to the membrane surface is a major regulator of potassium channel current during health and disease and in babies. So there are important drugs that affect potassium channels. There's diazoxide. It is a potassium channel opener, and it decreases insulin secretion. In contrast, we have sulfonylureas, which do the opposite. They close potassium channels, leading to increased insulin secretion. So key point number 3, early neonatal hyperinsulinism is caused by a low glucose threshold for insulin release. So transitional newborn hypoglycemia is a form of hyperinsulinism. And again, it's caused by lower glucose concentrations that actually stimulate insulin release. So there were these very elegant studies done at CHOP by Yang et al. They used rat freshly isolated perfused islet cells. And what they did was they wanted to determine the threshold for glucose-stimulated insulin secretion on the y-axis when they stepwise increased the concentration of glucose in the cell from 3 to 25 millimolar, or 54 to 450 milligrams per deciliter. So interestingly, these late rat embryonic or P1 islets responded to the very lowest glucose concentration, 54, by increasing insulin release. Now, importantly, later on, later in neonatal, day 3 and day 7 and day 14, and adult islets, they begin to secrete insulin when glucose levels are about 90 to 180. So newborns during the first 48 hours may develop transitional neonatal hypoglycemia because they have this lower glucose threshold for stimulating insulin release than older children, than older infants, children, and adults. Again, it's due to hyperinsulinism. And importantly, it's important to remember that insulin in utero is an important growth factor, and it's believed that it takes time for the insulin levels to go down after birth. So why do early newborns actually have a lower glucose threshold for insulin secretion? So point number 4 that you need to take home: the low early neonatal glucose threshold for insulin secretion is caused by decreased trafficking of potassium channels from the cytosol of the cell to the surface membrane, plasma membrane. So this cartoon shows cytosolic potassium channels, and as they move towards the cell membrane, and they can only work once they hit the cell membrane. So the early neonatal period low glucose threshold for stimulating insulin is really caused by a slow trafficking of these cytosolic potassium channels to the beta cell membrane. And this leads to insulin secretions at the very low glucose concentrations that we see in babies. Eventual trafficking of potassium channels from the cytosol to the membrane is necessary to decrease insulin secretion in that 24 to 48 to 72 hour period. So in conclusion so far, all forms of neonatal hypoglycemia are due to hyperinsulinism, including transitional, perinatal, stress-induced, and congenital hyperinsulinism. Again, they involve the potassium beta cell potassium channel and secretion of insulin. The presence of closed, functioning, genetically normal beta cell surface membrane potassium channels, that is what stops the unrelenting secretion of insulin and the resulting devastating hypoglycemia. It is believed, and there is more and more evidence, that transitional and perinatal stress-induced hyperinsulinism is likely due to in utero hypoxia, which is a signal for reduced potassium channel trafficking from the cell cytosol to the cell membrane. And that leads to transient or prolonged hyperinsulinism. Again, both of these eventually resolve. And the congenital hyperinsulinism is due to genetically abnormal beta cell potassium channels, even when they make it to the cell membrane. So looking at, there is a group called Congenital Hyperinsulinism International. They have global registries of more than 400 babies and their families with genetic or congenital hyperinsulinism. And they found that many newborns with genetic hyperinsulinism are actually discharged home from the nursery or the NICU without a diagnosis and without screening. And only 60% of the newborns that actually have congenital hyperinsulinism had an abnormal blood glucose test before being discharged home. So the traditional newborn hypoglycemia screening programs by the AP, by the Canada, British, Swedish, and other, including the Pediatric Endocrine Society, they do not meet criteria for being good screening tests. It has to be that you're screening for a disease, and I hope I've shown you that transitional neonatal hypoglycemia is not a disease. It's a normal physiological process. And perhaps instead of doing all this hypoglycemia screening and sticking all these babies and taking them away from their moms to the NICU, perhaps routine newborn bedside screening of glucose and ketones before discharge could be used in order to screen for the more pathologic forms of hyperinsulinism, the perinatal stress-induced and the congenital. So I just want to show you that perhaps the brain can use other important alternative fuels other than glucose. But I'm going to show you that in the first several days, they cannot and do not support the brain when babies are hypoglycemic. So this shows the 50th percentile from the 3rd and 97th percentile in the first 48 hours of lactate concentrations. And in normal newborns, some people say you can have levels up to 5, but others say 7 to 10 in the newborn period is normal. And the brain can use lactate for energy. Next, we have beta-hydroxybutyrate. And you can see it peaks around 48 to 72 hours. And there has been teaching that's wrong that says the reason why breastfed babies who are hypoglycemic do well is because they have high ketone levels. Well, in those first 24 hours, the ketone levels are very low. So the brain is not protected with higher ketone levels. This data comes also from the GLOW study that Deb Harris did in otherwise healthy breastfed babies. So one of the really cool things that they did was they converted the glucose, the beta-hydroxybutyrate, and lactate to ATP equivalents during the first 5 days in these healthy term, mostly breastfed babies. So blue is glucose, this orange is lactate, and the green is ketones or beta-hydroxybutyrate. And I hope you can see that glucose is the primary energy source for the brain. From day 1 to day 5, it provides up to 72 to 84% of the ATP that's used by the brain, or that's in the body. And newborns try to compensate for low glucose concentrations by using these alternative fuels such as lactate and ketones. But I've shown you they don't provide very much ATP equivalents. In fact, as I showed, lactate peaks on day 1. Ketones don't peak until 36 to 72 hours. And importantly, one of the things that happens when you have high insulin levels, that suppresses both ketogenesis and lipolysis. So ketone levels are low early on, so you can't use those to make up for low glucose levels. So unfortunately, alternative fuels cannot compensate for low glucose concentrations to the brain. Thus, severe, prolonged, and persistent hypoglycemia leads to brain injury. So my suggestion for a simple screening test, and our group just wrote a paper about this. I actually have to quote that. It came out recently in 2024. We can make use of what's known about insulin physiology. At 48 hours after birth or just before hospital discharge, for every baby, we suggest checking glucose and ketone levels at the same time. So, are your glucose concentrations low at 48 hours? If the answer is no, send the baby home. But if the glucose level is low at 48 hours, now use that ketone level that you got. And our ketone levels low at 48 hours. If they're not low, that means that the baby is fasted and they just need more calories. But if ketone levels remain low, that suggests hyperinsulinism, and perhaps it's congenital hyperinsulinism, and these babies deserve the full workup. So my conclusions from this talk are, even though we stick more than 30% of babies to screen for transitional neonatal hypoglycemia, it has never been demonstrated to lead to long-term adverse effects, and no one has ever shown that treating it improves outcomes. Second, transitional neonatal hypoglycemia is due to transient hyperinsulinism, and that is due to a low glucose threshold for insulin secretion, and this is because newborns have delayed trafficking of their potassium channels from the cytosol to the surface membrane, probably due to relative hypoxia in utero. Open, genetically normal potassium channels on the surface of the beta cell, that's what leads to decreased insulin secretion. So the hyperinsulinism goes away. And instead of the traditional newborn hypoglycemia screening programs, and I told you the AP is coming out with a more complicated screening program in the face of there is no evidence that transitional neonatal hypoglycemia causes brain injury. We suggest bedside monitoring of glucose and ketones before hospital discharge should be used to screen for persistent and prolonged hyperinsulinism. So this is your baby's brain, and this is your baby's brain on low glucose. And I'm now ready to answer some questions.
Wonderful. Thank you so much. That was great. Really illuminating. I was wondering if you could, until people might chat in some more questions. I had one, which is you mentioned that one of the prolonged states of neonatal hypoglycemia is not responsive to diazoxide.
Yeah.
But I felt like in my time as a neonatologist, I have seen most infants respond to diazoxide. I was wondering if you could talk a little bit more about that one that's refractory to diazoxide, and maybe I misunderstood.
So the babies that are responsive to diazoxide, almost all of the babies that have perinatal stress-induced hyperinsulinism, i.e. SGA babies, HIE babies, almost all of them respond to diazoxide. So it's not a problem of an abnormal potassium channel. It's just that it can't get to the cell membrane and it can't stay open. Diazoxide opens these potassium channels, changing the membrane ionization, I guess. A majority of babies with genetically abnormal potassium channels, most of them do not respond to diazoxide. Now, some do. there are a bunch of other medications. There are lots of research drugs being tried, like glucagon agonists and others. But in the end, if you do a PET scan, you can find if this congenital or genetic hyperinsulinism is focal or is it diffuse. If it's diffuse, truly, many of these babies need subtotal pancreatectomies, up to 97%. And they still, even 3% of a pancreas, they still are hypoglycemic for months or years. But ultimately, most of those babies end up with diabetes. If there's a focal area, you just cut it out and you're cured. Someone asked a question. Here, I'll go to the chat. Were babies in the GLOW study breastfed or formula fed? I would say they were like 98% of them were breastfed. And it turns out, interestingly, because these values were blinded, 39% of these otherwise healthy breastfed newborns in the first 5 days had hypoglycemia, i.e., less than 47. That's their cutoff. So that's the answer to that question.
Great, thank you. Another question was just chatted to me.
Yep.
Can you please clarify, why does the ketone level rise by 36 to 48 hours, even though insulin level is also increasing at the same time?
No. So insulin levels, because the potassium channels by 24 to 48 hours in an otherwise normal baby have made it to the cell membrane, they then stimulate insulin. They decrease insulin secretion. So in otherwise normal babies, insulin levels go down after 12 to 24 hours. But insulin itself, when it's high, it suppresses making ketones or making a lipid. So that's the mechanism. I hope that cleared that up.
Yeah, that makes sense.
Yeah.
Thank you.
So I don't know how many of our babies have awakened us in the middle of the night in the NICU. And we admit them and we do all the paperwork and we stick them many times and we put in IVs. And most of these babies don't have persistent or prolonged hypoglycemia. What the heck are we doing? It's really interesting that people have been studying neonatal hypoglycemia at least since the 30s, the 1930s, and we still don't know exactly what to do.
Yeah, absolutely. Go ahead. Yes, you have a question or you want to go ahead?
That was great, Dr. Kaiser. I really enjoy your talk. Can you expand more on the screening, what you are suggesting? So you are suggesting to screen to identify baby with hyperinsulinism.
Yep.
Are you suggesting to screen all, or could you expand on that? It's one of the best new thing I've heard.
So it's good and bad. The only way to pick up 100%, well, nearly 100% of newborns with genetic or congenital hyperinsulinism is to screen every single newborn. And we suggest, and I'm part of Congenital Hyperinsulinism International that has mostly pediatric endocrinologists. We're trying to figure out a way so that 50% of these babies don't go home, crash, come back to the hospital with brain damage. The only way we have figured that out is, and it turns out probably ketones is the most important. If your ketones are still low at 48 hours, you likely have hyperinsulinism, and you likely need to do a full workup. Until we prove in some studies that we're not hurting enough babies to find the other babies, it shouldn't be done yet. But if you look at the principles of a good screening test,
Yeah.
and the AEP, the Pediatric Endocrine Society, they're terrible because probably transitional neonatal hypoglycemia is not even a disease, so it doesn't even fulfill criteria. Explain that to the moms that you bring their babies to the NICU.
So that's my worry. We will not stop doing what we are doing currently. And we are doing, many baby will be discharged before 48 hours. And rest, I'm not saying, I think, does it fit the screening criteria, the new screening? It fits the criteria for good screening test.
So it is a better screening test because you're looking for a disease as opposed to a normal physiological condition. So right then and there, it fulfills that first criteria. The test is not expensive. We believe, again, with not a lot of data, that it's very sensitive. It's not very costly. And if you can save these babies from needing to be readmitted to the hospital with brain damage and caring for these babies throughout their whole lives, it is probably cost effective, but we have not proven that. Clearly,
if you need help proving that, please include us. We'll be happy to do something.
We would love to. We just put in a grant with CHOP and UT Southwestern and Duke and Penn State and CHOP to maybe start to answer some of those questions.
That's great.
Well, I hope I made people think about things that they didn't think were problematic. That's always been my purpose in neonatology. And I thank you for the opportunity to speak to the fellows.
Yeah, we're really so pleased that you could join us. Thank you so much.
My pleasure. Have a good day, all.